I'd like to welcome you to this Improving Data Quality Collection and Completeness for Systemic Anti-Cancer Therapy in Prostate Cancer. This is a webinar which is being coordinated and run by the National Prostate Cancer Audit.
Good morning.
And
I'd like to welcome you to this
and it's an important topic because when we're looking at the National Prostate Cancer Audit data, we're absolutely dependent on having accurate data in order to work out who's getting what treatment and to work out what the effects of those treatments are when we're looking at the longer term follow-up in real world populations. It's my great pleasure to welcome the team. We have Sugeeta Sukumar, who's a NATCAN Clinical Oncology Research Fellow. We have Justin Liu, who's one of our medical oncology research fellows at the NPCA in prostate cancer. And I'm delighted to welcome two groups who are going to give their experiences of using SACT therapy and recording data. Rob Duncombe, who's Chief Pharmacist at the Royal Marsden and a former alumnus of the Christie Hospital many years ago. Welcome, Rob. And we will also be joined by Louise Donickey from the Central Lancashire Hospitals, what we used to know as Royal Preston Hospital, which is the centre, and the Rosemere Centre at Preston looks after the Lancashire area. So I'm going to hand over now to Justin Liu, who's going to talk to us about SACT data quality. But before I do, just a reminder that we need to answer any questions which are forthcoming, and that should come through the Q&A section in your little toggle on the screen. You're also very welcome to use the chat facility, and we'll try and answer what we can as we go. We're going to finish promptly at 10 o'clock, and I think we're in for a good hour. Thanks very much. Over to you, Justin.
Thank you, Noel. I'll just share my slides if that's okay. Can you see that on the screen?
Yes, we can.
Thank you so much. So hi there, good morning everyone. I'm Justin Liu and I'm currently one of the clinical fellows for the National Prostate Cancer Audit. And I'm going to present on SACT data quality and completeness in the NPCA. So one of the most recent performance indicators from the last annual NPCA State of the Nation report published last year was the proportion of men with newly diagnosed metastatic hormone-sensitive prostate cancer receiving systemic treatment intensification in England. It showed that in 2022, which is the latest gold standard data available, 47% of men newly diagnosed with metastatic hormone-sensitive prostate cancer received some form of systemic treatment intensification therapy within 12 months of diagnosis in England. Now, when the results are dichotomized into age categories of under 75s and 75 years and older, there's a significant reduction in the proportions from 66% in the under 75s age category compared to 29% in the 75 years and older category. Further analysis also reveals significant levels of national variation. Now, the two funnel plots shown on screen represent the under 75s on the left and over 75s age categories on the right, and are adjusted for age, comorbidities, frailty, and socioeconomic status. Each blue dot represents an NHS organisation at the level of the specialist MDT and are plotted around an expected average, which is the straight line, and 95% confidence limits or 2 standard deviations, which is the inner curved line, and 99.8% confidence limits or 3 standard deviations, which is the outer curved line. The SMDTs highlighted in red were identified as negative outliers and were subject to our outlier process. Just to note, alarm outliers, which are those SMDTs 3 standard deviations or more away from the expected national average, were removed from the final NPCA State of the Nation report in 2025 following engagement with the outlier process. Finally, the top performing team in the under 75s age category was Lancashire Teaching Hospitals, highlighted in green at the top, and I'm delighted that the team from Lancashire and South Cumbria Cancer Alliance are joining us today to share their experiences. These are just some of the findings from the outlier process, together with quotes from specialist MDTs that responded. I won't go through all of them, but a recording of this webinar will be made available online following the event. Essentially, all of the SMDTs suggested that the problem was due to data quality and completeness issues as opposed to a clinical issue, And following this presentation, we have Dr. Sukumar, who will present on SACT data flow. So we also undertook a deeper dive with the team based at the Royal Marsden, who identified a local issue with novel oral hormonal therapies not being counted within their routine SACT data submissions. This is data taken from Cancer Stats 2, which shows the absolute regimen counts of these 4 medications on the right by month from 2020 to 2025. And as you can see, there are big gaps within the data sets, which can't feasibly be explained clinically, pointing more towards a data quality and completeness issue. The team at the Royal Marsden were able to rectify this following data resubmission to the NDRS, and you can see that the data is now much more complete in the graph below. And I'm delighted that Rob Duncombe from the Royal Marsden is also joining us today to explain further. The NPCA has also recently launched an online data dashboard on its website using quarterly data from the Rapid Cancer Registration dataset, and there's a QR code on the right here to access the link. It presents specific performance indicators over a 3-year time period at quarterly increments, allowing healthcare providers to monitor their performance at regular intervals and track progress over time. It's currently limited to NHS trusts in England. This is just using the Royal Marsden as a case example again. And you can see that they are now performing better than expected compared to previously, where they were identified as a negative outlier. Just in terms of the next steps, we're planning on an active feedback initiative to selected NHS trusts and SMDTs based on quarterly data dashboard reporting, which is due to launch in the second quarter of 2026. We're also exploring the use of CDF and BlueTech data to aid SACT data quality and completeness. And finally, we're aiming to continue transitioning away from audit reporting to active quality improvement based on frameworks that the NPCA has developed. Thank you for your time. Our contact details are listed here, and I'll hand over to my colleague, Dr. Sukumar, to present on SACT data flow.
Thank you, Justin. Perfect. So I'm just do a quick overview really of the currently set up data flow that's been set up by NDRS. Next. So this can be found on NDRS's website, and I'll post the links in the chat shortly. So essentially what I'll be focusing on today is the upload process of how the SACT files are submitted, followed by regimen mapping and file submission. Next slide. So submissions are essentially done through the API 3 portal, and this portal applies to all other data sets, including the radiotherapy data set as well. And what this interface allows is progress tracking of uploads that trusts will submit. And this is uploaded as CSV files. And the format in which SACT datasets need to be uploaded is specified by NDRS. And what NDRS do is monitor these monthly submissions and will flag those with significantly lower than expected numbers. And they have an escalation process in place. Next slide. Once files are on the system, what happens then is that the data goes through a process where the regimens themselves need to be mapped. For example, a chemo and immunotherapy combination, immunotherapy, the specific titles where these regimens that are uploaded need to be put into these specific categories. If for some reason the regimen hasn't been reported before, a conversation will happen through the portal between the hospital pharmacist and the national pharmacist that work with NDRS to discuss and agree which pot this regime should essentially be put in, or if a new regime name needs to be created. Next. The importance of understanding this process because on NDRS page is actually a schedule. So for example, data in November needs to be uploaded on the portal by January. And they advise that trusts do this earlier on in the month because what happens is that sometimes when files are uploaded, errors might come up. And you can do this by clicking on batch report. And within the action tab, there's an error summary highlighting any severity of errors. So for example, there's a critical error, files then need to be removed. The change needs to be made and re-uploaded onto the portal. And this needs to be done within the month itself. And along with the regimen mapping process, if, for example, there's a new trial or a new regime, again, any issues there need to be resolved within 15 days, and the submit to the registry data has to be done by the subsequent month. Therefore, any conversations that happen between the pharmacist teams on the portal and any errors should be resolved within the time period, and therefore it's unlikely to contribute to any missing data or lag. Next slide. And again, this is just giving an overview. So again, the SACT data is uploaded by either the local pharmacist or data manager, that is then mapped by the local pharmacist. Following this, if there's any issues with it being rejected, the national pharmacist will provide communication to the local pharmacist to log back on, remap any rejections for approval, and then the trust ultimately log back in and officially submit the file. And in terms of the key roles, from speaking to different trusts, NDRS have named the SACT uploader, cancer manager, and lead pharmacist as key contacts. However, these roles may all exist in each trust or sometimes carried out by the local pharmacist alone. So in terms of the input of the SACT data set, in terms of compliance, that can be seen on the Cancer Stats 2, which is done on a monthly basis, and any input that needs to be done is done through the API portal. So I hope this gives you just a bit of a setup and overview so that it can help understand the case examples today. Thank you.
That's great. Thank you so much, Sugi. Really appreciate it. It was a really comprehensive overview of SACT data flow, and I think it's something which we work very closely with our pharmacy colleagues to do, and hopefully, as we've demonstrated, it's really important to upload these things correctly and promptly to ensure good quality and completeness of data collection in SACT overall. Thank you. So next up, we have Rob Duncombe, who's the Chief Pharmacist at the Royal Marsden Hospital, and he's going to be speaking on his local experiences and what they do at the Royal Marsden with regards to SACT data quality and completeness. Thank you for your time, Rob. I'll hand over to you.
That's great, and hopefully everybody can see my slides and everything. So thank you ever so much for the invitation to come and talk this morning. I guess one of the first things to say is, yeah, I'm absolutely passionate about the sort of the SACT data set, and I think it is a completely amazing resource, and I think probably it's one of those unique things that we've got in England that we ought to sort of love and cherish and make the most of. I mean, I think probably the first thing to do is just sort of demonstrate and share before we move on to some of the issues we had at the Marsden over the past few years that Justin's alluded to, is how sort of I utilise and can utilise the SACT data set to support sort of the work that I do. And one of the things which I was closely involved in a number of years back was an initiative to dose standardise chemotherapy across England. So we were in a situation historically for many years where all chemotherapy, both oral and IV, was very much tightly dosed on the basis of numbers of milligrams per kilogram, which really resulted in that every patient received a very bespoke dose of chemotherapy. Now, that's pretty illogical when you think about it, given all the other factors that impact upon how a patient responds to a dose of chemotherapy. And what we did in mid-2015 or so is to launch a sort of initiative to dose standardise, dose band chemotherapy, which really harmonised the dosing of chemotherapy across the whole of England. It was quite a significant piece of work, but the outcome from that has meant now that across the whole of England, no matter where you're treated, chemotherapy is dosed in the same way. Our computer systems are now designed to dose standardise and dose band in the background. And we know that it probably reduces errors in dosing. It significantly reduces waste, because it means if a bag of chemotherapy is not utilised for one patient, then we can use it for another. It's encouraged commercial compounders to actually start manufacturing and commercially making bags of chemotherapy, again with long expiry dates, licensed products. And we know that through dose standardization, it sort of has saved the NHS probably in excess of £50 million a year just by the utilisation of standardisation. Now, that was all really well and good, and that was brilliant, and we sort of felt that we were making some inroads into sort of getting the adoption of the national dose standardisation. But the one thing we weren't able to do very well is to figure out how much uptake we actually had of this and how many doses were now being prescribed in accordance with the national dose bands. And again, working with colleagues who were looking after the SACT data set at the time, they were able to introduce some functionality into Cancer Stats, which actually has a tab in there which looks at SACT dose banding. And what we were able to see is that, looking at that data, we now know that sort of 98% of chemotherapy in England is actually prescribed in accordance with the dose bands. So again, a really powerful way of collecting data and utilising that data to actually show this initiative that we developed in terms of chemotherapy dose banding had massive uptake. And also then we were able to identify those trusts and those organisations which still weren't complying with the national dose band. So we're able again to tailor our approach to those few organisations which hadn't fully adopted the national dose bands. I think again, you can get some wonderful graphs and stuff off the SACT data set. And again, this is just in terms of docetaxel, and I did this earlier in the week, just looking at the prescriptions for and the doses of docetaxel prescribed in England from January 21 to October 25, and then looking at the compliance with the national dose bands versus those prescribed outside of dose band. And what we can see is almost 100% of docetaxel is now prescribed in accordance with national dose banding. And so again, a really powerful way of showing the power of this data and the ease with which this data is being collected. I've got no idea how we'd be able to do this if we didn't have the national SACT data set. But obviously, I think, as Justin's alluded to, that all of this is totally dependent upon the quality of the data that we upload to the system. And obviously, if the data going in is rubbish, then we don't get the power of results that we're looking for. So, as Noel said, I arrived here at the Marsden in 2021, having spent a number of years in Manchester at the Christie. And one of the things, obviously, when I first arrived here at the Marsden was to start, again, saying, okay, well, how does our SACT data compared to others, and does it show what we're expecting to see in terms of SACT activity? Because obviously, from my perspective as chief pharmacist, there's something which is really useful to me to know, sort of both in terms of growth, in terms of chemotherapy activity, but also particularly growth in terms of oral dispensings of chemotherapy, and what proportion of our chemotherapy is oral versus what proportion of chemotherapy is now IV, because that then impacts upon my decision making in terms of how I manage the department, the strategy for the pharmacy department, whether I invest in further aseptic units, whether I invest in further aseptic compounding, or whether I need to put more resources into building more dispensaries. And obviously, having that kind of data at your fingertips from the SACT data set is really useful, and is, again, in terms of putting together business cases, is a really powerful tool. However, what I discovered when I arrived at the Marsden was something quite concerning, that I think you can see on the slides here, that effectively our chemotherapy administrations at the Marsden are totally flatlined. And this was really actually from sort of even pre-January 2020, that, on the face of it, what it looked like in terms of our administration count, we were doing significantly less chemotherapy activity at the Marsden than compared to many other smaller institutions. And, particularly, we have a little blip in 2023 that's related solely to when we introduced our EPIC system. But even after the introduction of EPIC, actually, our data quality didn't improve. So there was something seriously amiss here, that sort of, post the implementation of EPIC, we were still looking at around about 6,000 administrations per month, with actually no growth in activity whatsoever. Whilst obviously on the ground, I knew that looking at the issues data from the pharmacy, the number of patients attending for treatment, that our growth in terms of activity was similar to other parts of the country in terms of a growth of sort of between 5 to 8% of chemotherapy administrations year on year. So there was something seriously amiss with our data. So I certainly made quite a lot of noise within the trust and a number of forums to say, we've got an issue here with the quality of data in terms of our SACT return, which if I can see it, then it does mean that everybody else can see this as well. So we have got an issue here. So as Justin said, yeah, we've done some work. We've managed to do a retrospective upload, and we're now actually seeing what I suppose post sort of that upload in sort of December 2023 onwards. We're kind of seeing what we expected to see now. We're seeing an upward tick in terms of chemotherapy activity. We are, up to around about 8,000 administrations per month, which is on a par with what I'm seeing through pharmacy data as well. So I'm far more assured now in terms of our data quality than I was previously. So, what were we doing wrong, and what have we done about it? So I think, I have to say, I certainly noticed this and certainly made a fair amount of noise about it, and other people in the organisation started to notice it. And it's one of those things that I found that, you need to raise the profile of this and put it onto other people's agenda as well. And I think sort of very important to note that, to tell people, well, if I can see this by just logging on to the Cancer Stats website, that means everybody else in the country can see this as well. And other people can go on there and say, well, you know what, the Marsden is actually not delivering any more chemotherapy than it did in 2020, which obviously is patently wrong. And then what we can also then do through sort of Cancer Stats and the data set is actually, really interrogate the data right down to individual drug levels. And so one of the things we did do was actually go into the data set and say, well, compared to other places, what are we missing? And what we identified was that absolutely drugs like abiraterone, enzalutamide, pembrolizumab weren't actually being reflected in our data set. And obviously, given the growth in these drugs over the past 5 to 10 years, it's hardly surprising that we weren't seeing much of an uptick in activity or no uptick in activity whatsoever. And so we was able then, through sort of the utilization of this data, to go back to our informatics team and say, well, this is where you need to be looking, guys. This is where we've got an issue with our data set, because these drugs are not appearing in our SACT returns. And I think, what we found the cause was very much built around how we designed our data collection and build. And this all predated EPIC. Whilst we'd introduced EPIC, if the issue is actually around about how you've configured your drugs and how you've put markers on your drugs, there's those drugs which need to be included in your SACT dataset return versus those which don't. If those drugs are still post-EPIC, have still got the same markers on them, then we're still going to be missing them in our sort of an analysis of that data. So as I said, we didn't have a flag on those drugs. Those drugs weren't then picked up by the systems that the informatics team were using to identify drugs that should be uploaded to the National SACT data set. But obviously, as soon as we got buy-in from the people we needed buy-in from, we've got a monthly SACT board at the trust, which has got large attendance from across the oncology community. And it's then started to become sort of everybody's issue, not just sort of my issue and a couple of other people's issue. I think the other thing which we're able to do again is to start to share the power of the data set with others, and other people can then start to analyze our data and see what was missing. So in the end, I think what we found was that, some relatively small fixes in terms of how a small number of drugs were configured and built into our drug build actually changes everything. We've identified those 4 or 5 high volume drugs that were missing from our submission. And then as soon as they had the right flags attached to them, as soon as we were able to do a retrospective upload of the data, everything, fell back into sync again, and everything started to look really good. I think the other conclusion from this is, again, that ongoing close scrutiny of the data and ongoing oversight of what we're submitting, and that close relationship really between the pharmacy and the informatics team are absolutely crucial in terms of making sure that the data set is maintained. So thank you, and I'm very happy to answer questions after.
Thank you so much, Rob. Really appreciate it, and it's so nice and so inspirational, I think, to us all to hear from you, from someone who's so passionate about the National SACT dataset and the data that comes from it. And yeah, we'll take questions and answers at the end, if that's okay. Thank you to all those who have submitted questions and through the Q&A tab at the top of the screen. If there are any other questions that people have, do feel free to post them in the Q&A tab. So thank you again, Rob. Our next speaker is, I'm delighted to welcome Louise Donickey, who's one of the cancer managers at Lancashire Teaching Hospitals, who's here today representing Lancashire and South Cumbria Cancer Alliance. Hi there, Louise, nice to see you. Who's going to be speaking about their local experiences as as one of the positive outliers from our recent NPCA findings. And yeah, I'm really excited to hear what she's got to say and some of the local experiences. So thank you so much for your time, Louise. I'm extremely grateful, and I'll hand over to you.
Thanks, Justin. Hopefully you can see my presentation.
I think it's just loading up now.
Just loading. Okay, sorry about this. I'll just, okay. It's coming, like Christmas. Okay, so yeah, thanks for the opportunity for sharing our experience with everybody. And it was very welcome, because we're usually on the naughty step for most things. So to actually be a positive outlier made a really good change. What we think of as business as usual, when we'd had discussions, you thought was really good practice and you wanted us to share that with everybody. So first of all, I just wanted to say exactly who we are, where we fit. So our alliance is made up of 4 trusts. You can see there, we're just one of them, we're the tertiary centre. Those 4 trusts are made up of 8 hospitals, all of which deliver chemotherapy. Population of about 1.8 million. Dread to think what that will be soon with all the houses that's going up around here. We have 1 tertiary centre, which is ourselves, that deliver radiotherapy, and we currently have 2 site robotic prostate surgery, ourselves in East Lancs. We have 4 local urology MDTs and 1 network MDT that meets every Friday afternoon. We have very strong clinical leadership and engagement, which supports our chemotherapy and urology clinical reference groups. We've got a couple of professors in there as well. And we do have a consultant therapy radiographer as well, which really supplements the team. So what systems do we use? Of course, we use iChemo currently for our SACT. I think what we have in our alliances, I think in 2007, it dates back as far as that, we were the first network with a single system that we use across all 4 organisations. And originally we had Varian. We switched to iChemo in 2019 and we fully migrated all that data across with us then. That pulls all our bloods and results from our PAS interfaces, our EPR interfaces that we've got. So 1 system across all 4 organisations. We actually use it as well to book our radiotherapy through. So all the booking forms go on through there. So all the oncologists, whether they are in the, a hub and spoke model, they can all access all the data. Our data manager that sits within the cancer services team is the person that uploads the SACT data. And what we do with that as well, each month we'll pull all that data and use it for our cancer waiting times. So we do a cross check to make sure that we're not missing any treatments in recording that. Part of that then is recorded on the Somerset Cancer Register for our cancer waiting time submissions. And I think we're quite unique in our area that we all have 4 separate Somerset Cancer Register systems, but we all have access to each other's. The firewalls allow us to do that because of one of our other systems that IT have worked on, and that's our shared care records. So that sits across all 4 organisations again, and primary care. So we can see the GP interactions and interventions. So all clinical letters, all radiology reports, all endoscopies, etc., all sit on the shared care record, so everybody can access each other's system. So as part of what we do as well, if we get a chemotherapy or a radiotherapy subsequent treatment that's not known to us, we can quickly jump on another system and pull that staging, performance status data through as well. It just helps to supplement everything. We also have a lot of people involved here, and again, even though it's hard to recruit sometimes up here in the Northwest, what we have got is organisational memory. A lot of our pharmacists and chemotherapy nurses have been here since the very inception, so we've got all that wealth of knowledge and information and history. Our chemotherapy booking teams as well all work very closely together. The oncologists again work cross sites. We do have, most importantly, an iChemo system manager. He was part of the procurement and he watches the system very carefully. He helps design mandatory fields. He shares learning across all different organisations. He comes on site and does visits across. So what happens well in one hospital site, he'll bring that knowledge back to another. We've got everybody involved, medical secretaries, MDT coordinators, trackers and navigators, they all use the system. And what we did as well, where you said at the Royal Marsden you were an outlier because of the drugs that you didn't record, we've always included those, and I think that's why we are a positive outlier. Because everybody from the outpatient nurses all have always, it's embedded now, it's just common practice, it's our normal day-to-day. Yeah, so basically that's it in a nutshell for what we do. So thanks for listening, and hopefully it's common practice everywhere else too.
That's great. Thank you so much, Louise. That was again incredibly inspirational, and thank you for all that you do. There's so many learning points I think that we could all take from what you do locally. So that was an absolutely amazing presentation and a real eye opener, I think, for all of us. I'll hand back to Noel now, if that's okay, and we can perhaps have a bring all the presenters up on screen to have a panel Q&A discussion. Thank you.
Thank you, Justin, and thank you to all the presenters and some fascinating insights into just how different systems work and how others have caught up, having realised that there are problems in the system, and that's something certainly which we picked up in the National Prostate Cancer Audit. We have a question from Stephanie Harrison in the chat, sorry, in the Q&A, and it relates to Suki's presentation. And the question is, did you replot the funnel plots for SACT prescribing after investigating removing extreme outliers to see if this revealed additional outliers that warranted further investigations? Suki, I don't know if you can address that.
I think I might have to pass this one to Justin, just because of the final plots by prostate team, to see whether it was repeated. Thank you.
Yeah, that's absolutely fine. Thank you for the question. So Marina has already answered the question, I believe, in the Q&A tab. But just to update everyone listening, no, we didn't replot the funnel plots after the alarm outliers, which were the ones which were 3 standard deviations or more away from the expected national average, once they were removed. And like I said, the reason for their removal was because the trusts that were in the that were identified were we did engage with them and found that all of them were negative outliers because of data quality issues as opposed to clinical issues. So there was an explicable reason as to why they were there, and it wasn't related to any clinical issues as such. It was a data quality and completeness issue. which we will be continuing to work with those trusts to try and improve moving forwards.
Thank you, Justin. I've got a supplementary on that, really. One of the things which is apparent in the NPCA is the spread of data in relation to SACT. And clearly some of that is underreporting, and Rob will come back to that in a minute. And interestingly, the Christie also featured as one of the lowest prescribers of SACT in the country. Which is just impossible, really. The two biggest cancer hospitals in the British Isles under prescribing. That raised alarm bells for us. So Justin, just give us a view, your view, having had a look at this, as to the spread of data and how the funnel plot works for those who aren't familiar with how these things are presented.
Yeah, thank you so much. So what I'll do is I'll just share my screen again, and I'll take you to our data dashboard, which is something that the National Prostate Cancer Audit launched alongside NATCAN, which is the National Cancer Audit Collaborating Centre, which is based at the Royal College of Surgeons of England. And we launched this in January, and this is available. This is freely available online for anyone to see. And this is the web address at the top, and I believe that it's been posted in the chat as well. Essentially, this takes you to the landing page for the National Prostate Cancer Audit, but like I said, the other cancer audits within NATCAN also have their own data dashboard pages, and essentially it allows individual NHS trusts and organisations to see what their latest results are for a variety of performance indicators. So what I'll do is I'll on the left hand side here, you've got a choice of either quarterly reporting, which is based off quarterly data from the Rapid Cancer Registration dataset, which is produced more rapidly, as the name suggests, but perhaps slightly less granular and slightly less accurate than what we call gold standard data, which is data from the NDRS. That we include in our annual State of the Nation reports. So if you select the Performance Indicators tab on the left here and play around with the various toggles, I'll just take you through. So for example, if you were to select Lancashire Teaching Hospitals, for example, you can see their performance for for systemic treatment intensification in metastatic disease shows up like this. And so this is the graph looking at their performance, and the sort of dashed black line in the middle is the expected national average, and then that's around two control limits at 95% confidence intervals. And as we've already alluded to, their Lancashire Teaching Hospitals are performing above the expected national average consistently, which is really reassuring to see, and that's up to the end of 2023. Like I said, this is based on quarterly reporting, so these indicators will be updated quarterly, and I believe that the next batch of data available will be from next month, covering the first quarter of 2024.
And so that is very helpful, Justin. But for the listeners, viewers, what do you do when we see somebody who is an outlier, essentially underperforming? What kind of process is there for validation of data?
Yeah, absolutely. So I think it's so within the NPCA, we have something called the outlier process, which is a formalized process which is based off which is based off national guidance, which essentially details a process whereby once we identify a perceived negative outlier, it's not immediately to say that trust is doing badly. It's just an indication that they are outside an expected national average, and we engage with them through a formalized process, which we can link more information to in the chat, and we aim to work with trusts to identify the perceived issues and to try and help improve them. So the case example in point here is the Royal Marsden, where we were able to work with Rob and his team at the Royal Marsden to identify an issue with uploading novel oral hormonal therapies that are commonly used in prostate cancer, which weren't being done so initially, and then they were able to re-upload and resubmit the data to NDRS, which saw a dramatic improvement in the numbers prescribed.
And we'll come to Rob and Louise in a minute, but just before we do, the initiative through BlueTech. So just for those to kind of broaden this out a little bit, one of the problems we had within the NPCA was working out whether somebody was a true outlier. In other words, they were under-prescribing, in our view, SACT treatment, and how that differed from a group that were probably prescribing appropriately but not recording, was difficult to discriminate. One approach that we adopted and are continuing to develop was through BlueTech. Now, the notion that somebody's going to prescribe an expensive drug, we all know as prescribers that you have to go through a process of validation, in other words, approval. And we thought that if we could get hold of the money, effectively follow the money trail, that would lead us to where SACT prescribing was appropriate, in our view, and within the confines of the funnel plot, or whether an outlier, as we saw it at the NPCA, was a true outlier. So, Justin, I don't know if you want to just have a talk about that. And
yeah, absolutely. Thank you, Noel. So I think it's important, just for those who are unaware, just to really cover the history, I suppose, of the Cancer Drugs Fund and BlueTech. So just very briefly, the Cancer Drugs Fund was established by NHS England in 2016, which acts as a separate source of funding for so-called high-cost cancer drugs in England. And the list of those high-cost cancer drugs is growing all the time, and the lists are readily available on the internet. And essentially what the CDF does is that it provides access to promising new treatments via managed access arrangements or individual funding requests through an online portal known as BlueTech, whilst further evidence is collected to address clinical uncertainty. Now, the CDF, like I said, itself provides interim funding for all newly recommended cancer drugs, giving patients access to those treatments many months earlier than before. And the actual system is managed centrally by a team called the Medicines Value and Access Function within NHS England. So essentially, when patients are prescribed a high-cost cancer drug in England, clinicians also need to complete a separate BlueTech form, which captures linked patient-level data, including their NHS number. The drugs themselves are stratified according to disease stage and clinical indication, and additional clinical information is collected according to NICE criteria, and can include things like treatment start date, histology, performance status, etc. Now, like I demonstrated in my talk, current data from the National SACT dataset is not always necessarily an accurate reflection of treatment rates in routine clinical practice. And therefore, CDF and BlueTech data, which is a separate data set or data source, could potentially act as a slightly more accurate surrogate measure of prescribing rates of high-cost cancer drugs, and then almost enable filling in those gaps. Now, on top of that, it could also help potentially address delays in national SACT dataset reporting, which is currently about 15 months compared to CDF and BlueTech data, which is collected in real time, and also enable improvements in things like risk stratification and granularity in reporting. And actually having an accurate SACT dataset will also benefit kind of research both within the NPCA and more widely across the other cancer audits within NATCAN and other organisations as well.
So there are other ways into getting that data. Sugi, just briefly, you had a comment there about useful links in the NDRS. I don't know if you just want to elaborate on that, and then I'm going to come to Rob first, and then Louise after that.
Yeah. Thank you, Noel. So yes, so in the links there, just to highlight where the data flow map is currently from NDRS, and along with that, the current escalation process, and they have a quite a nice step-by-step guide as well in terms of how the data should be uploaded, how the fields, what fields are important, and they are actually going to be updating their data set soon. So they've actually got a link to a video as well, just to explain the new changes to the SACT data set that they'll be implementing soon. And NDRS are actually planning on updating their resources in terms of the data flow map to make it a bit more intuitive and easy for trust to follow and troubleshoot any local issues. And the NPCA team will be sure to, update the trust and any communications you have as well as part of the QI intervention. Thank you.
Okay, thanks, Sugeeta. And keep your questions coming if you have them. We'll endeavour to answer them. Rob, if I might come to you, a great overview talk, I thought, in a very short space of time, and you've done a lot of work and saved the NHS an awful lot of money. That's terrific work. What I'd like to know in your chemotherapy prescribing was, how did you bring the outliers into line so effectively? What measures did you use?
I think, I guess it's sort of multiple. I think mainly it's the embarrassment factor. When you start, and I suppose it's at the Christie as well, when you start making a lot of noise around about, we are an outlier here, this is a national data set that, not only can I look at it, but everyone else around the country can look at this as well. And at the moment, anyone, as I said, externally looking at our SACT data for the past 5 years will be drawing the conclusion that the Royal Marsden is doing less chemotherapy activity than far smaller organisations. And, there are some real issues here. And as you said, this data is useful, and a lot of people start looking at it and utilising it to actually sort of make decisions around about investment and the utilisation of medicines. I mean, the other part of it is, I think as Justin's alluded to, actually, uploading data to the National SACT data set actually isn't just a nice thing to do. It is mandated. It is part of the commissioning thing from NHS England that, when we get nice approval through for a drug, we get a letter come through from our commissioners. And within that, along with sort of making sure that we complete the blue tech, there is a line in there which says trusts must ensure they're registering the drug use on SACT. The SACT dataset is mandated dataset, part of the Health and Social Care Information Standards, and listed in Schedule 6 of the NHS Standard Contract. And then in bold print, it says payment of trust invoices will be contingent on blue tech registration, the full SACT and CDF MDS record applicable to the drug being completed. So I think, it comes at it from a number of angles. As I said, there's the embarrassment factor that, it shows that we're not, doing as much activity as we like to think we are. And equally, this is actually mandatory and we have no choice in the matter. And sooner or later, a commissioner, if they were so inclined, could actually turn around and say, you know what, you're not fully compliant with your contract and we're going to start doing something about it.
And the experience in the NHS, and I'm sure in the commercial world, is if people don't get paid, it doesn't get done. And so if this data isn't coming in from a hospital, well, the hospital's losing money, which it shouldn't necessarily lose. So I wanted to ask you about this SACT board, which is a new concept to me, because I'm pretty sure we don't have one.
Yeah, so at the Marsden, it's one of the things which I kind of worked on when I arrived here, that I realised that doing SACT is totally multidisciplinary, and an awful lot of hospitals are organised in kind of silos. So you've got, a cancer services division, a clinical services division, and hospitals work along divisional structures, whereas the delivery of SACT is completely multidisciplinary. That, we are more dependent and interdependent upon everybody to deliver the SACT service and operation and deliver it well. And so one of the things we introduced at the Marsden is a monthly 2-hourly SACT board meeting, where we just invite anyone and everybody who's got anything to do with the delivery of SACT to come and talk about SACT delivery for 2 hours on a Friday. It's chaired by myself as chief pharmacist and Elaine, lead nurse. But we have representation from oncologists, medics, nurses, pharmacists, operational managers. Anyone who is involved in delivery of SACT is welcome to come. And again, that's a really useful forum for sharing information like this, and actually then through that group saying, okay, we're going to form a task and finish group, and we're going to bring it back to our little SACT board every month until we see this as being resolved. And again, it's just a useful way to sort of de-silo the management of SACT.
Which is great. I've got a supplementary to that, and as you may or may not be aware, around the British Isles and in Europe is a big kind of debate going on at the moment over in prostate cancer, the prescription of SACT drugs, which in the UK and particularly England have been cost limited with restrictions on urological prescribing, and that's led to, excuse me, inconsistency in certain areas. So there are urological oncologists, surgeons who wish to prescribe SACT drugs and who can now prescribe, but are somewhat restricted in certain areas. How do you bring those on board? And in an area like, for example, Lancashire, where you have peripheral hospitals, going up to Barrow-in-Furness, I think, if I'm correct, Louise, how do we get those drugs to patients, and how do we get the information out of those centres, which aren't necessarily big cancer centres like the Rosemere or the Marsden?
I guess partly it comes down to, and hopefully all of us now are using electronic prescribing systems, or we should have been, introduced electronic prescribing systems over the past 5 to 10 years. And, much of this data collection comes through the system that you're using, both in terms of, the prescribing of the drug and then recording the administration of the medicine. And, I guess look to Louise and others, that much of this data now is collected electronically, and it should be agnostic as to who's actually doing the prescribing.
Well, to give you an example, tomorrow morning I'll do a clinic at Salford Royal, which looks after the West of Manchester. And if I want to prescribe enzalutamide for a case, I simply click in, I seek Blue Tech approval, and then I can write a paper prescription straight off. Now, that may not be collectible using an iChemo system, for example, but it is collectible through the Blue Tech system. And I think that's something that is, I'm not sure how we pick that up through the National Prostate Cancer Audit.
I said, yeah, because I suppose so much of this is built upon, as the data collection in terms of, systems like iChemo and our EPIC system. Everything is driven by the electronic data. And, I know full well that sort of collecting data on the basis of drugs I dispense from the pharmacy, is okay. But it doesn't actually tell me if those drugs have been administered to a patient or the patient has actually collected that medicine and started taking it. And that's the problem with utilising sort of your pharmacy dispensary system as a source of good data collection in areas like this, because it doesn't tell you whether the drug's actually gone into the patient or not.
I'll come back to you in a minute, Rob. I've got some other questions for you. But, Louise, just would you have a go at that and just see what your view is in the Lancashire area?
I'm not so sure that all of our consultant urologists would use the electronic prescribing system that comes through our iChemo, but I think with the high cost drugs, they go through our ACP nurses attached to oncology, so they're all directed and they're all trained to do that within outpatient clinics, and they are all prescribed and administered through that system. And
is it your view that there's an underprescribing in certain areas? You take Blackpool and the Fylde Coast, you take Barrow and even Whitehaven. I think Whitehaven comes under you. They're a long way away from any urological non-surgical oncologists, either a clinical or medical oncologist, aren't they? So that may mean that the people don't get the drugs. Do you have a view on that?
Access to, yeah. I think with the CRGs and the way that they cross primary care as well, I think there is that, and certainly in our patch, the GPs won't be involved in any prescribing, so they have to come through the hospital.
Okay, which leads me back to you, Rob, which is this question of drugs being flagged and not flagged, because in prostate cancer, the world is moving very quickly. Every year it's different. Every year it's new. And there are different drugs which come up. And you raised a very important point, really, which was that drugs like enzalutamide were simply not being flagged. How do you pick them up when they're coming through?
That's right. I think it all falls down to the system we utilise now in terms of making sure I've got the right people involved in the building of drugs and regimens. So as I said, we're now using Epic, and I guess other people on the call maybe use Epic. It's an incredibly complex system. I think a drug build on Epic has got something like 1,000 fields you need to complete. And the danger is if you miss one flag somewhere in those 1,000 fields, then it can impact upon the data collection which falls from that. And part of this then is actually making sure that I've got the right pharmacist and the right pharmacy team actually scrutinizing this stuff at the point of drug build, because absolutely someone within our informatics team is not going to know that a hormone should be part of this data collection. And and it is that posing that question. We've got the same thing with some of the immunotherapies as well, is just because it doesn't make your hair fall out and give you myelosuppression, doesn't mean that it's not a SACT agent. And it's this definition that we have got to get clear on, is what is a SACT agent versus what is chemotherapy, which is what is a cytotoxic drug. Because the danger is if you're only going to be collecting data on your things which are cytotoxic, you may well be missing an awful lot of SACT data.
Yeah, so that's an awareness issue, isn't it? And something that might come through something like a SACT board.
Yeah, absolutely.
But there's got to be kind of feed upwards from the clinicians and the specialist nurses, and an approval and recognition. Otherwise, everybody loses money and the patients lose out. Louise, could I come to you? You've done a fantastic job on pulling all those information systems together. How did you do it?
It's not me. I can't take any credit for it. It's our IT systems. We have, and I don't know the ins and outs of it, but they call it a coin that they've got, so we've got our own little network going on here. So yeah, it would be all our IT infrastructure teams.
So one thing that was a really standout, I thought, was that you can link into GP records.
The shared care record, yeah.
Yeah, so as Rob has just alluded, we don't know whether when a drug is prescribed, if it's carried on. And increasingly, we're trying to devolve some of that prescribing to GPs. Of course, we can't prescribe some of the androgen receptor pathway inhibitors, the ARPIs. The GPs won't prescribe those yet, but one could imagine when these come off patent and so on. So would you just give us a bit more detail about that GP record, what you can actually get from it?
Yeah, through all our EPR systems, there's a little icon that you click on and it takes you through to the shared care record. So anything that's in there from other organisations you can see. So you actually on a patient level, you can see any of the systems that we've got, but also you can click on the GP button and it takes you through to the GP EMIS system, so you can see prescriptions, visits, you can see tests, results, and likewise the GP can see our results through an iSystem, so they can look up all the clinical, as soon as the letter is published, they see it. So, gone are the days of posting things, so discharge summaries, any clinical letters, any pathology results, blood results, radiology reports, they're all there instantly.
Yeah, so that's fantastic, isn't it? A great data access. And we've just got access to elements of GP prescribing through the NPCA, which I think will be a fantastic resource. You did mention, both of you, Robert and Louise, about the importance in relation to data collection, flagging appropriately, and remuneration that comes with that. There is one aspect which I'd just like to advertise in the NPCA, which is the long-term outcomes, because this has real clinical impact. If the data is accurate, we can pick up who's got what when. We can then look at the things like social deprivation. We can look at comorbidity. We can look at what individuals have got. And we can then look at the effects of these drugs in terms of cancer survival and outcome. But importantly, we can pick up such things as toxicity, which is really, really important when you're coming to multifactorial prescribing with ARPIs, with ADT, with chemotherapy, and so on. And we can get that in large scale. So I can't emphasize enough the importance of being able to collect this data, follow it longitudinally, and see where pockets of compliance are there. When there is no compliance, what we do about actually making something and bringing people into line, much in the way you said, Rob. The embarrassment factor, but the money factor, I think, is a really important thing. But equally, are we giving drugs and other therapies, radiotherapy, for example, which might in the long term, over a 10 or a 15-year time period, be disadvantageous to certain elements of the population that we serve? And I think that's a really important point. So we have a couple of minutes left. I wonder if anybody's got any questions from the panel, or whether anybody's got any additional questions coming in from our audience.
Thanks, Noel. There's a question from Benjamin Starmer about data quality checks and deep dives performed on NHS trusts and organisations not deemed an outlier. How do we know that the data from units within the funnel plots is accurate?
Well, do you want to take that?
Yeah, so
you did address it to some extent.
I did, yeah, thank you. So we've already been replying to the question within the chat, but essentially we trying to perform deep dives with every single NHS organisation is, quite an undertaking, and not something that we prioritise at the minute. At the minute, we're prioritising those trusts which are negative outliers, and also working with trusts which are positive outliers as well, to also learn from them. In terms of data quality checks, as Rob's already alluded to, that there is a certain minimum data standard that is mandatory, that needs to be submitted to central organisations within NHS England, and we rely very much on those individual organisations submitting the data to ensure the accuracy. And this is something that the NPCA works closely with NHS trusts and organisations to try and achieve.
Thank you, Justin. Well, it's been a fascinating hour. Time's up. I'd like to thank Louise and Rob. Fantastic work and really helpful insights. And I hope that that has spurred on the enthusiasm to get the data correct, because it's good for patients, it's good for hospitals, and keep up the good work. Thank you very much for listening.